Hello, everyone. It's my pleasure and my honor to welcome you tonight to one of our weekly online series. On behalf of the Educational Board of the Mega Medical Association and the Egyptian Society of Anesthesiology, I would like to welcome the speakers, moderators, and attendees to the creative and prestigious continuous opportunity to deliver not only an up-to-date curriculum in the field of anesthesiology, critical care medicine, and pain, but also to gather unique speakers and moderators from all over the group. This opportunity is and will remain a great and successful experience in the current and the future virtual learning. Let me introduce Dr. Gloria Rodriguez Vega tonight. She's better known as Glory, and she's a Puerto Rican-born internal medicine critical care neurocritical care specialist, a magna cum laude graduate from the Cornell University, and later cum laude from the Universidad Central del Caribe School of Medicine. She finished her internal medicine residency at the VA Caribbean Healthcare System, and afterwards completed her critical care medicine fellowship at TMH Brown University. She returned to her beloved PR to direct the VAC Surgical ICU for 6 years, after 4 years directing the UDH Neurosurgical ICU. She moved in 2010 to direct the Neurosurgical ICU at Jaime San Pablo Caguas, a private hospital conglomerate in the island. At present, she is also a chief of the Department of Critical Care Medicine. She's assistant professor at the University of Puerto Rico School of Medicine, Ponce School of Medicine, and Universidad Central del Caribe School of Medicine. She is currently involved in the numerous international and international societies. She is a council member of the Society of Critical Care Medicine, and she's president of Consejo Centroamericano y del Caribe de Terapia Intensiva, a former council member of the Federación Panamericano Ibérica on Medicina Crítica y Terapia Intensiva, and past president of the Puerto Rico Society of Critical Care Medicine. She has been a speaker at the local, national, and international level, and has publications in peer-reviewed journals, authored books, chapters, and is a co-editor of the books Critical Care Administration, labeled A Comprehensive Clinical Guide and COVID-19 Pandemic Lessons from the Front Line. She lives happily with her beautiful daughter, 2 opinionated dogs, and an understanding husband. Dr. Rodriguez, it's all yours now.
Thank you, Ahmed, for that kind introduction. And I am excited to present this panel. We will be talking about sepsis, and as you know, sepsis is a medical emergency, and it is the final common pathway to death from most infectious diseases worldwide. 1 in 5 deaths worldwide is associated to sepsis. Sepsis is the #1 cause of death in hospitals, the #1 cause of hospital rehospitalizations, and there are significant healthcare costs associated to this disease. On September 13th, we celebrate the World Sepsis Day, and this event is part of that celebration. And as you know, this is an internationally recognized initiative of the Global Sepsis Alliance, which aims to increase public awareness and show support and solidarity with the millions of people of the world whose lives have been affected by sepsis. Here at MEGA, we have prepared this program with sepsis as a recent update with opinion leaders in this topic. And it is my honor to introduce our first speaker, Dr. Jorge Hidalgo Marroquín. Jorge is a very good friend of mine, and he's well recognized as an international speaker. He is professor of critical care medicine and head of the division of critical care at Carl Huesner Memorial Hospital in Belize, Central America. He is also president-elect of the World Federation of Societies of Critical and Intensive Care Medicine. He is past president and founder of the Consejo Centroamericano y del Caribe de Terapia Intensiva, COSECATI, and he has been awarded with the highest recognition of both the American College of Physicians and the Society of Critical Care Medicine as Master. For the last decade, he has been director of the very prestigious ACP review course, And he is also recipient of the Global Sapphire Award, becoming the first Latin American intensivist to get this award. He is also a fellow of the American College of Chest Physicians, and he is author of several chapters and books in critical care medicine, among them critical care administration and highly infectious diseases in critical care. He is also part of the group who has been involved in the writing of the Survival Sepsis Campaign guidelines, and he is involved in numerous congresses as a speaker and as an organizer. He will be talking to us about sepsis pathophysiology. Jorge.
Yes, let me share my screen. Just to start saying that the definition of sepsis is something that has been in constant development for the last decades. And of course, our understanding on the pathophysiology and the immunological mechanisms of sepsis definitely has improved. However, the steps of how to have a therapeutic approach is still a challenge, despite of all this progress that we are doing. And then one of the factors that is critical is the timing diagnosis, the initiation of the causal supportive, and also all the different adjunctive therapies that we can apply. And probably one of the most important things is after all these 3 decades is that we are still thinking that it's really, really important to create awareness, and that's the reason for this meeting, to promote quality improvement initiatives in the field of sepsis, and of course with the idea that we need to rethinking the process and see what are the different things that we can do as a collective group. Saying that, I want to introduce myself. I'm Dr. Jorge Hidalgo. I am the president-elect of the World Federation of Intensive and Critical Care Medicine, and presently I am the head of the Intensive Care Unit and COVID-19 Unit at Belize Healthcare Partners in Belize. At the bottom, you have my different contacts. It should be a pleasure for me to keep in contact with you guys if it's the case. But one of the most important things I want to also tag is that we have some things to disclosure. We have the Technosepsis group that started in Palma de Mallorca, Spain, where our group is essentially dedicated to the technology and the advanced basic science on sepsis. Also, we need to disclose that we soon will have our Sepsis Codex, who is one of the books with the latest on sepsis, reviewing from the basics to the phenotypes and many other interesting aspects that we need to cover in sepsis. And also, I want to extend my gratitude to Dr. Sad Madi, and also to congratulate to keep this tremendous effort on keeping these sessions and keep us abreast with all the continual medical education that he is conducting. And thank you, Glory, for your introduction. And also we have an excellent group. I mean, that saying that, I want to basically start with what we know. We know that sepsis is a life-threatening condition, and of course it's a global disease burden. And also we know that this is an heterogeneous syndrome, and thinking on that, based on that information, the sepsis last definition basically focus on an organ dysfunction, and basically say that sepsis is a process where we have an organ dysfunction that is caused by a dysregulated host response to infection. But of course, one of the interesting aspects is the emphasis that we have on the immunopathology that we are going to cover today. And if we think on that, we know that that sepsis essentially is a multifaceted disruption of the finely tuned immunological balance of inflammation and anti-inflammation. I mean that we can say that in contrast of an uncomplicated localized infection, sepsis various areas of disruption of the finely tuned immune system. And of course, we will see that it's a cascade of upregulation of the pro and anti-inflammatory pathways that essentially leads to all this a continuous cascade of inflammation that we need to control, and of course all of us as an intensivist are excited to that, but it represents a challenge for us in ICU when we have this type of patients. I mean that the most important thing is how these different processes start. And to be able to trigger and to initiate this cascade, we need to have a successful pathogen that must attach and cross the different barriers of protection that we as a human have, and escape all this defense system and multiply to ensure their own survival. And we say that all these invading microorganisms with sufficient load and virulence can cause sepsis. However, and you are going to agree with me that there are several pathogens that are well known for this impressive arsenal to attack the host. And what better example of that than SARS-CoV-2, that we experience and we are still trying to end this pandemic, but also it allows us to learn a lot on the process and recognition of sepsis. I mean that I think so this is a good example of this impressive arsenal to attack the host. I mean that the starting signal after we have these pathogens that invading is that we have different key molecules that we need to start to learn, and we are going to try to talk about some of them during the course of this presentation. And then we have these specific molecules like the recognition of pathogens that are essentially coming from molecular patterns, the PAMs. Also, we have endo and exotoxins, lipid DNA sequencing, and different others endogenous hosts like the damage-associated molecular patterns that they are going to initiate all this clinical syndrome of sepsis and starting a cascade of events that it will end it with our patients in ICU. And of course, the main purpose of us as an intensivist is to try to stop this continuum and this continued cascade of events at some point, and that is basically the idea. I mean that we have this impressive arsenal of events, and then we have the balance of the immune response. Then we know that the activation of the innate immune depends on the interaction between all these different mediators, the pattern of recognition, the different pathogens associated molecular patterns, the damage associated molecular patterns. And then we have these different events that are essentially seen right here. We have the inflammatory response, we have the early inflammatory response where we have all these mediators. We have the cellular immune response, and we have the humoral immune response. And we need to try to control those events. We have in the bottom, the anti-inflammatory events. But also, at some point, as we are going to review in the course of the presentation, also we have something that we call it the quality control of the cells. And the quality control of the cells, it will create different mechanisms that it also can induce that we call it immunoparalysis. And in that type of events, we will see that it will make our patients vulnerable to have other type of nosocomial infections. And then if we are unable to stop all these events, we are going to have either a deterioration of our patients, and then we are ending on multi-organ failure, and then of course we are going to lose our patients. Mean that this other cartoon is very interesting because essentially what we see is the interaction between the dams as well as the neutrophil extracellular traps of nets. And what we essentially see is that we have all these different mediators, and one of them that is important is the inflammasome. And it's going to create a continuum and events of inflammation, and it is going to perpetuate inflammation through the trigger of all these different mediators, the NFKB and the inflammasomes. And it will end with endothelial damage as well as the compromise of the epithelial cells with injury. And we are going to see what is going to cause in the endothelium in the next slides. One of the others, if we can say new player, and this is very important because then it comes with now over us as an individuals. It will we need to have into account our improper eating habits, lifestyle, our metabolic disorder in vivo, our cellular damage, and different others endogenous danger signals like the fatty acids, glucose, cholesterol. But what is important, because then we have a new term. We already know about the dams and the pumps and the different receptors of recognition, but we have this new player that we call it the metabolism associated molecular pattern, and of course that is important because it will alter the balance. We see that the balance is broken, and then we have all these metabolic disorder that also it will help us to a decrease in our cells ability to repair. Mean that it will essentially make us prone, and it will to sepsis, and it will also help to perpetuate all these different inflammation events. Mean that also this is something that is create and gaining a lot of importance, and as well as we are going to see in the next also two speakers that we will talk about the different phenotypes and in the different changes as an individual, and how that it will impact our understanding of sepsis and also our approach to sepsis. I mean that we will hear a little bit more of the MAMs in future presentations. I mean that of course one of there are several elements of inflammation that are critical, and the nets or the neutrophil extracellular traps are essentially released from neutrophils during inflammation, and we can say that essentially are webs of extracellular DNA decorated with stones, mieloperoxidase and elastase, and although nets contribute to pathogen clearance, excessive nets also it will basically contribute to the formation and promotes inflammation and tissue damage and sepsis. No, I mean that this one is an important player in this continuum cascade of events. No, and this one is to illustrate essentially all the different damage that the nets have. It's important to understand that essentially these nets contribute to the continuous pathogens and promote inflammation and tissue damage in sepsis. No? I mean that other important player that we need to understand is also that the immune system is a team effort as well as an intensivist. No? We always talk about collaboration, and one of the close collaboration and the close is the complement system that basically plays and together with other pro-inflammatory and inflammatory mediators to stimulate, and one of them is the cytokines. I mean, the complement system attacks dangerous cells or pathogens, as well as phagocytic cells that can respond more properly after activation. However, in sepsis, this team is dysregulated, and of course, we see that the work is inefficient to use the complement system. I mean that saying that, we need to understand that the complement activation and the products of complement, especially the C5a anaphylotoxin, is critical in the understanding and probably some of the different targets on the different areas of therapeutic areas of investigation. One of those are trying to address complement C5a as part of therapeutics to trying to control sepsis. No? I mean, and during sepsis, the appearance of these complement products is followed by the appearance of extracellular histones in plasma, which also have a powerful pro-inflammatory and prothrombotic activity that cause cell injury and multi-organ dysfunction in models in mice. No? I mean, that is our understanding and participation of complement are very critical. No? I mean, that is an illustration of the complement activation, the pathophysiological consequences, and also what is going to happen, especially the anaphylotoxin C5a, and how this will essentially contribute to the generation and the perpetuation of inflammation, and also to contribute to activation of polymorphonuclears, monocytes, macrophages, and also it will help to generate nets and mets and release extracellular histones. And if we are unable to stop all these processes, then we are going to see our patients that is going to progress from sepsis to septic shock and multi-organ failure. I mean, this is our comprehension of that is critical. No? Also, we see right here in this cartoon the complement activation and also the interrelation work with nets to mediate thrombosis. No? And we see an important participation of the anaphylotoxins or complement C5a and also the C3b that activate different neutrophils. And again, it will perpetuate inflammation and it will favor the creation of clots. We see again in this when we're trying to understand what is happening with the different damage of the endothelium and the developing of edema, then we see cytokines and other inflammatory mediators that induce gaps and also work interrelation to trying to promote thrombus formation, creating an alteration on the deformity of the red blood cells, activate neutrophils, alter the vascular endothelium, and favor the development of thrombus. No? I mean that again, this is over different processes and the continuing cascade of inflammation that we need to be able to control. No? Also, as we can see right here, also the different areas of different other mediators. We have cytokines, we have also the disassemble of the different cell junctions that at the end, what is going to favor is going to favor the creation of the interstitial edema. We are going to see an important vascular leak and interstitial edema, and we will see different mediators of inflammation that are going to be responsible for that. And one of the important mechanisms that we have is the endothelium. We see that the endothelium plays an important role to understanding these processes of decompensation and compensation in our patients, and if we're trying to imagine our vessels, and then when we have in the progression of sepsis the vasodilatation, and then we have the participation of the different mediators like the dams and the pumps, and that is going to essentially trying to create that we call it that the glycocalyx dysfunction. And we need to remember that the glycocalyx is critical to trying to maintain the stability of the cells, and all this it will along with the oxidative stress, it want to create two things. One is going to cause a glycocalyx dysfunction, those different mediators. It want to create an endothelial activation and dysfunction, and it will essentially lead to all this altered endothelial communication that it will end it with problems and alteration of the microvascular flow, and it will create edema and endothelial leak. I mean, that is a very important process that we need to understand. Now, if you see this slide, is to illustrate that the cells have something that we call it a quality control steps. Then the cellular metabolic downregulation that we see early in sepsis, and the cells that we are going to do is going to create a different type of adaptative mechanisms with the main idea to try to prioritize consumption of energy and trying to limit the injury and trying to maintain energy balance, prevent DNA damage, and preserve cellular composition. Mean that all this is happening at the same time. We call it a quality control of the cell. We will see more in the next slides. No? Mean that this is an important also slides, because it will, you know, we will see that despite that we have oxygen, then what we are going to do is going to be a preferential oxidation glucose to glycolysis. And again, as I say, despite that the availability of oxygen and aerobic glycolysis, we have this phenomenon that the Warburg phenomenon that basically we start to see in patients with cancer, But using this mechanism, the immune cell reprogram the pathways of energy generation, and trying to say that we can say a housekeeping processes to trying to maintain the equilibrium, and is done theoretically for two important reasons. One, doing these mechanisms of aerobic glycolysis and fatty oxidation changes, it will allow for the production of essential structural components like fatty acids, amino acids, and nucleotides, and that it will allow the cell to have sufficient energy for their own cell survival. And the second important aspect of this is because this glycolytic basically will help us to use ways like the pentose phosphate pathway, increase glycolysis that will essentially reduce the oxidative damage of the cells. I mean that is the purposes, the theoretical purposes of this process, no? That we need to we are seeing in the quality control of the sepsis. And the other important thing is what is going to happen with the mitochondria, the phenomenon that we already see, and then we know that our cells are in constant process of fluid, growing, dividing, and continually responding to the environment. Mean that what essentially see right here is a quality control within the cells that involves a variety of self-regulating activities, which keeps essentially our reserves of proteins, a balance between the different proteins, and of course the participation of the mitochondria is critical. And then essentially what we describe with these adaptative metabolic processes is something that we can say like a checkpoints. I always say this is as basically checkpoint with the police, and essentially where the cell is going to verify if is ready to advance to the next step. And if the cell is not ready, then we will essentially experience that we call it the cell cycle arrest, that will prevent the energetic cause of replication, but that can also prevent cell death in the setting of a cell injury. But of course, one of the things we are going to see also is an important inflammation process that will, at the end, it will cause problem, and it will lead to microvascular dysfunction. I mean that those are the different processes that we are familiar. But now, another important player that is gaining our attention is the microbiome, the systemic microbiome, who essentially is a diverse of microbial community that influence health and disease. We know that essentially also as a healthy body, humans, we have an abundance of bacteria, viruses, and fungi that we acquire during the life. But the bulk of this microbiome is in the gut. We need to also know that there are many other microbiomes in other systems, and like the skin, mouth, nose, lungs, and the genital tract. But the human microbiome is essentially have placed important roles in the maintenance of this homeostasis. But when we have this microbial population disrupted by any means, antibiotics, as we see in this new player, our own habits, it will definitely alter, and this disruption, it will allow to the germs and to the different inflammation to gain advantage, and it will result in a systemic inflammation and alteration. No? Mean that the microbiome is gaining a lot of attention Of course, we see that in sepsis, the composition of this intestinal microbiome that essentially is characterized by a lot of diversity, but we lost that diversity and lower the abundance of these key commensals, and essentially we see an overgrowth of opportunistic pathogens, and we experience that we got a translocation of bacteria. No? I mean, the immune response can further be compromised when this translocation of pathological microbes through a disintegrated epithelial barriers results in a systemic and lymphatic spreading of pathogens. I mean that the microbiome, that as we know, is consistent of trillions of bacteria, in which most are found in the gastrointestinal tract. And then we see and need to be familiar with terms like dysbiosis of the microbiome, that essentially means a decrease on the microbial diversity that is essentially being associated with alters in our immune response and how we essentially interact. And for instance, it will alter cytokines production capacity of these immune cells. I mean that is a lot of research going on the microbiome and our understanding of these important players, and is getting a lot of attention. I think so we will hear more and more, and also how this is going to interact and interfere as the way how we treat our patients with sepsis. I mean that this is the microbiota at work, just a cartoon to illustrate the different work at different levels. And then the advancing on human microbiota research is critical, and the most evidence linking the gut microbiota to brain phenotypes and behaviors in animal models. And these preclinical studies have informed strategies that we need to further analyze and have some particular intervention. And we see that what is needed to inform the causality in humans over understanding accurate controls, the understanding and the contribution on the different genes, environment impact, the definition and direction between cause and effect, and of course the important role to have a normal and healthy gut microbiota. No? But something that also is gaining a lot of attention, and then I believe Dr. Perez Fernandez and Dr. Marcio Borges, they are going to talk more. I just want to just briefly say that we know that sepsis is a very heterogeneous syndrome, and then the direction of that is that we need to basically go to a more individualized type of medicine based on our genotype and our phenotype, and also that is something that is gaining a lot of attention. No? I mean that saying that, and to summarize, we review the different pro-inflammatory responses and immune suppression. We talk about the lot of virulence and the different bacteria, and if it's that is possible, then it will trigger the participation of these dams and pumps and the metabolic associated mediators as well. The patterns recognition receptors and the activation of these different mediators, leukocyte activation, complement coagulation, activation, and also we talk about the different aspects of quality control of the cells, particularly on the reprogramming of the cells with the intention to preserve energies. And then if this continuum of inflammation, if we are unable to contain it, then the process is going to lead to septic shock, and multi-organ failure, where all these different organs are going to get compromised in a way in one way to other. Meaning what we are trying now is to pushing the boundaries of knowledge. Meaning we are together and trying to understand sepsis and see how, as a team, we can give our patients a better solution. Saying that, I want to thank you, and I want to invite you guys to the Intensive Care Congress organized for the Istanbul and the Society Turkish of Intensivists. It's the World Congress of Intensive Care, and hopefully you can join us in that event. One more time, thank you for the invitation.
Thank you, Dr. Hidalgo, Jorge, for this very thought-provoking lecture. I want to remind our audience that you can ask your questions via the chat. And in the meantime, I love that phrase, how you end your lecture, pushing the boundaries of knowledge. And in that, I want to ask, we have over 50 million patients of sepsis per year, 11 million die yearly. So why is it so hard to identify that cascade of events? Because when we look at sepsis therapies, they work in the animal model, but when you translate that to clinical trials, we don't get the results that we would expect. So why do you think it's so hard to identify that time zero?
That's a very good question, of course, and the 1 million question. Of course, one of the things we always say that hopefully that we have the ability to detect our patients on a very early stages, but unfortunately that is not the case. No, unfortunately, us as an intensivist, we work essentially for the patients that are referred to us. We don't have the luxury to see the patient at the very beginning. We see the patients on different stages. And that is the reason and the importance of meeting like this, because we need to create awareness, not only among colleagues, but also it's important that us as a physicians, we can also educate the community to try to identify and to advise them that they don't need to wait too long, and that a simple tooth infection, it can lead to a very fatal results if it's not timely detected, and also to refer to the properly patients. And as we review the cascade, the inflammation cascade on sepsis is really very, very fascinating, and we will love as when we have a patient with an MI that we have the possibility and the ability to control these different processes. But it's difficult, no? If we remember the sepsis effort and the sepsis surviving campaign between 2004 and 2008, all of us are very happy because we say, okay, we have the protein C derivatives, and we thought that we have our own thrombolytic medication if we want to call it that way. But unfortunately, it wasn't the case. No, I mean, we're still in this process.
Following up on what you have been explaining, and how we're going further in the molecular level, and you mentioned DAMPs, PAMPs, MAMPs, and all these other events. Do you think there is a role for biomarkers in identifying this T0, like I would like to call it? Are we getting closer, or we still haven't found that silver bullet with biomarkers in sepsis?
Yes, that is a very important question, and when we usually say biomarkers, and it's a lot in the market, no. But of course, we would like the biomarkers that is accessible, a biomarker that allows to make decisions in terms of what should be the best antibiotic. But unfortunately, we are still on that battle. Of course, and we definitely can say that is we are making a lot of progress, and it's a lot being done with that on that regards. But we are still a little bit far to have that biomarker that have this the different possibilities that is going to be accessible in terms of cost, and that is going to help us on the daily making day decisions.
One last question, and I know there are questions from the audience that I don't want to leave unattended. We have Jasser, and he asked how to prevent the damage of the endothelial glycocalyx in sepsis.
That is a very interesting question. Hopefully we have the answer, but that's all this cascade is a continuum of events, meaning that the most important thing is to recognize and to treat on time. Once this cascade of events is being triggered and is challenged for all of us as an intensivist to be able to control. There are many things that we can do, but I think so the key thing is to prevent that. The dysfunction of the glycocalyx is critical, and as you see, will basically cause an endothelial dysfunction that will lead to capillary leak and edema, and we want to prevent that because we know that when we see that on all this needs to have a clinical translation, meaning we need to see, okay, what we are seeing in our patients clinically, and how we can prevent that. When we see that our patients develop edema, we know that it's not a good sign.
Thank you. We have one last question for you, and I know there will be more questions coming up as we go along with treatment and personalized care with Dr. Perez and Dr. Borges. Knowing the depth of molecular basis of the sepsis syndrome, have we reached the phase of using immunosuppression in a similar way to using it in COVID-19, especially in refractory shock? I think maybe, I know Javier will be touching that during his lecture. But what are your comments and thoughts on the future?
Well, I think so, and if I want to say that the advances of that and the different areas it comes to that we call it the adjuvant therapies, nothing is essentially approved, and we have many advanced adjuvant therapies that has been proposed, but nothing that we can say that is a standard of practice at this point. But again, I believe Dr. Perez and Dr. Marcio, they will talk a little bit more on those aspects.